James McKiernan is our department chair for urology, and he's going to be talking to us about specifically the renal or the kidney manifestations of VHL.
Thank you. Thanks, Dr. Chung, and thanks for the invitation and the VHL Alliance's help organizing this. We've, as far as I know, never done anything like this here at Columbia before. A lot of us have been working together for a long time, formally and informally, but I think this is a great way to get everybody in one room. I hope we do it again. I have a disclosure to make before I tell you about the renal manifestations. I'm no brain surgeon, so this is not going to be brain surgery. This is going to be maybe a little bit more straightforward, but I couldn't help but notice in Dr. Bruce's presentation a theme, which I think you're going to hear throughout the day, which is understanding the biology of the syndrome and then sort of adapting and modifying your surgical interventions, particularly around the timing and the conservative nature of those interventions, which has definitely been a theme in the renal surgical field in VHL over the past 20 to 30 years, where we've figured out that sometimes you don't have to do as much, and you certainly don't have to do it as quickly, and conserving normal healthy tissue in the organs that are affected by this condition is one of the paramount objectives. And I think for people that don't deal with VHL a lot and deal with an organ, like the kidney, for instance, but don't understand the syndrome, they sometimes will overreact and do things like take out the entire kidney when you have one single cyst and it's small, and they waste a lot of the organs of interest. So if there's one theme I think you hear throughout the day is be cautious when it comes to when and how to do some of these interventions. So this is just what I'm going to try to cover briefly, similar kind of theme. Historically, this syndrome goes back a long way. It was first described by a German ophthalmologist for some of the retinal findings, whose name was Eugene von Hippel. And he actually noted that there were cerebellar tumors, and one of his patients actually went on to develop kidney cancer. Recognized this was before MRI scans, CAT scans, PET scans, biopsies, and most of the surgery you're going to hear about today wasn't even feasible at the time. And a Swedish pathologist sort of simultaneously published a series of observations in 4 patients with retinal and cerebellar tumors, and they all had renal cysts and renal tumors. So that's how the name kind of came about. Fast forward to the 1980s and early 1990s, when I was in medical school a long time ago, and the gene and the genomics of this condition sort of got unraveled, if you will. This is a 3-dimensional picture of the VHL protein, and a colleague of ours in urology, whose name is Marston Linehan, who runs the National Cancer Institute's program for genetic kidney cancer, and specifically VHL, working together with a pathologist named Burton Zabar, actually helped identify where this gene is physically. It's on the 3rd chromosome, and then sequenced the gene and published a few papers regarding what the gene does, and sort of led to a focused research lab effort at the National Cancer Institute in the branch of urology, which is our area, and it's obviously become known now as sort of the mecca of information and cutting-edge research for the syndrome. And that has kind of given us a lot more information about how common it is, how people can develop it, inherit it, and also develop it through an acquired somatic mutation. So as Dr. Chung, I'm sure, will tell you, not everybody has a family history of VHL when they're diagnosed, so there's some variations to the theme in terms of the genetics. And in kidney cancer, at least, it's led to an investigation of the pathways of the development of kidney cancer. So kidney cancer is the 7th most common cancer in the United States in men, and about the 10th most common cancer in women. And it turns out that people who don't have VHL, who get kidney cancer, which is the vast majority of people who get kidney cancer in the world, do not have VHL. They share a lot of the same genetic alterations in their tumor with the VHL syndrome, and it just occurs only in their kidney tumor. So loss of the 3P chromosome locus, or the area that the VHL gene sits in, occurs in the vast majority of people with clear cell carcinoma to some degree, either silencing of the gene or turning it off, or loss of the gene or mutation. And that has sparked a series of investigations that have led to an understanding of how kidney cancer actually happens, which is shown here, and has to do with the upregulation of some of the angiogenesis factors, or factors that lead to new blood vessel growth and formation, which is a common theme between all the organ systems in VHL that are affected. And in kidney cancer, it's now led to 8 maybe 9 new FDA-approved therapies for kidney cancer, which are applicable to people with VHL and those who have kidney cancer that don't have VHL. So this has served as a model of discovering how a cancer develops and has now been extrapolated to a complete revolution in the therapies that we have for kidney cancer. When I started in this field, there was no medical therapy for kidney cancer, none. Surgery was the only option. If the cancer came back again, palliative care was the only option. And we now have so many options, we actually don't know how to use them or how to combine them or which one should go first. And that's really all because of the understanding of the genetics and the molecular biology of VHL. A side story to that is that the lab at the NCI, because they became so expert in screening people who had genetic forms of kidney cancer, they actually started to describe and unravel several other genetic syndromes that lead to kidney cancer, which are actually not VHL. And here's just a few of them: the Birt-Hogg-Dubé syndrome and hereditary leiomyomatosis in renal cancer, as well as hereditary papillary renal cancer. These have nothing to do with VHL directly, but because of the effort and interest in trying to discover both a cure and an understanding of how VHL works, they've now become expert in identifying these forms of kidney cancer and helping us advise patients on how to treat them. So you already heard that the features of the syndrome involve the central nervous system. In the urologic system, depending on how you define the urologic system, the renal manifestations are the most common. The vast majority of people with VHL at some point in their life will develop cysts in the kidney, and cysts are basically fluid-filled structures that, at least on imaging, do not harbor cancer. About 50% of people at one point or another in their life will develop a cancer, and the most common is renal cell clear cell carcinoma. Pheochromocytomas, which you'll hear about from Dr. Lee later today, are adrenal tumors that sit right on top of the kidney. And then in men, there's a relatively rare and benign tumor that's referred to as an epididymal cystadenoma, which is essentially a benign cystic tumor of the sperm ducts and the testicle, which is outside the testicle, called the epididymis. The average age for a patient with renal cancer and VHL to be diagnosed is much younger than people with what we call sporadic renal tumors, which means tumors that are discovered outside the VHL syndrome. And it's usually in their mid-30s to early 40s, whereas with people with typical kidney cancer, it's much later in life, in their mid-60s. And one of the hallmark things that we look for is multifocality and bilaterality. So when it comes to advising doctors, which actually you are probably better at doing than we are, if a doctor sees a patient with multiple bilateral cysts or tumors and the patient's not diagnosed, they really should stop and take a step back. And what I find frequently happens is the doctor for your kidney just zooms in on your kidney and doesn't think about anything else that could be going on. If it's an undiagnosed patient, that's extremely dangerous, particularly since they might end up taking out a kidney or doing something that's not necessary if the tumors are small. The lining of the cysts are thought to be the area where the tumors develop, and in patients that have cysts that are larger than 2 centimeters, frequently some of those will be found to have tumors lying within the cyst. How to make the diagnosis, I don't want to spend a lot of time on that, but in general, you search for a family history and you look for the constellation of these symptoms. Thankfully today, the diagnosis can usually be confirmed by genetic testing, but usually the clinical symptoms and clinical syndromes that are linked are rare enough to happen sporadically. So any patient with retinal manifestations and a kidney cyst or tumor, pancreatic tumor, VHL-related hemangioblastoma, everyone who's taking care of them should stop, and the genetic screening process should come about. So for the kidney specifically, there are recommendations. Dr. Chung mentioned she'll hand out a table for this. We look very closely at renal ultrasound as the mainstay of screening. So for the asymptomatic patient, newly diagnosed with VHL, or with a strong family history, an ultrasound is completely non-toxic. It involves no radiation, and it has no dye or anything that has to be injected into the body. It's extremely sensitive to detect renal cysts, meaning if you have a renal cyst, it's very rare if you go for an ultrasound that they'll miss it. And then periodically an MRI scan, which actually covers the adrenal gland, kidney, and pancreas, is inserted into the screening and follow-up process, which is even more sensitive and more specific, meaning if it shows something, it usually can tell you whether it's a cyst or whether it's a tumor. And people that undergo these kind of screening tests with VHL recognize when you don't have a tumor or you have a single tumor, it's usually what we can see is what we're describing to you. Whereas if you operate on a patient who has VHL, who has a single tumor, and you remove their entire kidney, it's typical to find multiple, if not thousands, of microscopic cysts that are lined by early tumor cells, which in the 1960s and 70s made people think, okay, in that case, everybody has to have both their kidneys removed immediately, because look at all these tumors. But the reality is most of these tumors don't do anything, and they sit there and remain indolent for decades. So overtreatment was a big problem for decades, and I still think there is some degree of that in the United States. So the goal of treatment is really to preserve renal function whenever possible and control cancer if there is a malignant tumor, and frequent follow-up and monitoring and extremely close surveillance after the treatment. The remaining gold standard, or the current gold standard for treatment, is what we call partial nephrectomy or nephron-sparing surgery. You'll hear that term used. Nephrons are the cells in your kidney, and not removing your entire kidney whenever possible is the gold standard. It does not reduce the risk of recurrence, like you heard about in the cerebellum. You can have another tumor, and VHL syndrome is not fixed by any surgery, so the kidney itself that's left in after a partial nephrectomy can and frequently will develop another tumor, and that will have to be addressed later. So multiple surgeries are not uncommon in a single patient on the same kidney. So one of the biggest recommendations for intervention, I'm going to move now to what do you do when you have a tumor in the kidney, is that, and this is a relatively modern recommendation, you don't do anything unless one of the tumors exceeds 3 centimeters. And I want to go back a little bit in time and explain sort of historically why did we make that recommendation and why is that currently one of the quote-unquote cut points for intervention. And the theme here is that if you react to every tumor the moment it occurs, you're going to end up with a lot of surgeries really quickly, and you're going to end up losing a lot more kidney function. And that in the vast majority of patients, particularly in VHL, who have a tumor that's less than 3 centimeters, it does not spread. So how do we know that, and where does that come from? So this has been looked at predominantly at the NCI, and most major university centers have gone back in their own series and confirmed this, but this is one of the studies that led to the quote-unquote 3 centimeter cutoff. They had 181 patients at the time with renal tumors at the NCI. This was a long time ago. They have a lot more now. And they looked at people who had solid tumors less than 3 centimeters that were followed until the largest lesion broke the threshold of 3 centimeters. And then they had another group who came in and showed up right away at diagnosis with tumors that were larger than 3 centimeters and underwent immediate surgical resection. So they started off with tumors above the threshold. And they tried to see what was the rate of developing recurrent cancer and metastatic cancer in both groups. So in the first group who underwent nephron-sparing surgery, these are people who had smaller tumors that were watched and didn't have anything done until they became bigger than 3 centimeters. 97% of the patients who underwent surgery were able to have a surgery that did not take out their kidney. So in other words, you could save most of the kidneys even if you did not operate until the tumor got bigger, whereas when people walked in with larger tumors, a higher proportion ended up having a total nephrectomy. So watching until something got bigger was a good way to maintain your ability to have a partial nephrectomy. And no patient in that group ended up with what we call renal replacement therapy, which is the medical term for dialysis or transplant. Right, so that's the ultimate thing that we'd like to try to prevent in any patient who's having a kidney operation is, can we wait until the tumor gets bigger and then intervene right when it gets bigger, but not take out one or both of your kidneys? And very few patients in any group develop metastatic disease if you operated at 3 centimeters. The likelihood of developing spread, which is the ultimate thing that we want to avoid in cancer, does increase with size. So a 3 centimeter tumor has a lower probability than a 10 centimeter tumor. But at 3 centimeters, there does not appear to be an immediate increase in the risk of cancer spreading. So watching a tumor from 1 to 2 to 3 centimeters does not seem to increase the risk of it spreading. But that does not mean you can watch it forever, and it does not mean that a 10 centimeter tumor is something that's safe to watch. Metastatic cancer in patients with VHL, tumors less than 3 centimeters, it's extremely rare. In fact, it's probably reportable, and usually it's because one of the tumors is bigger than you thought it was, or something's not right about the imaging, because it's very, very rare to have spread less than 3 centimeters. That's not true in sporadic renal cell carcinoma. So we really try to reset the clock, quote unquote, by taking out all the tumors that you operate on. Now, When you operate for a tumor that's larger than 3 centimeters, the patient often and almost always will have multiple other tumors, like you saw in the cerebellum. So you don't just operate or intervene for the tumor that's drawn you into the operating room. You try to remove all the tumors that you can during any surgery that you do so that the resetting of the clock doesn't change your tumor from 3.1 centimeters to 2 centimeters, which is your other tumor. So if you get them all out, then your clock gets completely reset, and maybe your next surgery can be a long time in the future. So that's the kind of concept behind why we do that. So when I say operate, that means cut out the tumor like Dr. Bruce showed you in the cerebellum. What are the other options for treating tumors like this in VHL particularly, and what about non-surgical options? So I just included another relatively large and historical study to point out when and where we try to use those options. So the main other option for a tumor is to ablate it with an energy source, not gamma knife, but something we call either cryosurgery or radiofrequency ablation. And these are essentially percutaneous techniques now that can be used with a needle to place into a tumor to either heat it with radiofrequency ablation and destroy it, or freeze it with a cryoprobe, which is something that can be used to cool the kidney down, to cool the tumor down rather, to a very low temperature. And these sound like great things because they don't involve an operation. The patient does not have to have major surgery. Generally, they do not have to have general anesthesia, and frequently can be done as an outpatient. And it can be done over and over again. So again, at the NCI, they looked at their experience comparing whether or not cutting out the tumor to ablating the tumor was better and when you should use which technique. And they looked over a period of time when they weren't really doing this and then compared it to a period of time when they were doing it. And they had a large number of people who underwent surgery. The mean age, for instance, of this group was 37 years old when they underwent the treatment. And 43 of the operations were done as a first ever surgery, whereas 70% of their operations were done as a second or even third surgery, sometimes in the same patient. They came their first surgery and they came back. And why do we mention that? Just like the brain, every operation we do makes the next operation harder because of scarring and the inflammatory reaction around the kidney. So a third or fourth or fifth partial nephrectomy surgery has an increasing risk of complications and loss of the kidney. So we look for ways to try to avoid that. In their experience, the people who got radiofrequency ablation had relatively smaller tumors with an average size of only 2 centimeters, and the interval between their second procedure and their first procedure was actually shorter if they had RFA, meaning you had to come back sooner to do another intervention, whereas if you had a partial nephrectomy, it lasted longer, generally because it could remove multiple tumors and it was more efficient at removing the tumors, although it was a bigger intervention. And they had 6 patients with quote-unquote treatment failure, where the tumor they treated came back again, which is almost unheard of for partial nephrectomy. If you remove a tumor, you may get another tumor, but the one you remove almost never comes back again. And basically their consensus review on this was that if you want to save a kidney, it's more likely to be saved if you do something less invasive like RFA, but if you want to get rid of all the tumors and have it last longer, an operation beats an ablation. So how do you translate that into when and where we do things? So a typical patient would have a partial nephrectomy, is multiple tumors, 1 or 2 of which are over 3 centimeters, and has never been operated on before. That's an ideal candidate. A patient who might be not such a great candidate for that is someone who has 1 tumor, relatively small, like just at 3 centimeters, has had 3 or 4 prior surgeries, and it's their only kidney. Their other kidney was taken out already. So the high risk of loss if you go back and reoperate on that patient, and you could probably take care of it, but the RFA probably won't last as long as the operation would have. So what are some of the consensus things I can sort of leave you with and wrap up for VHL in the kidney? The discovery of this gene was basically driven around the biology of kidney cancer, and it has led to massive breakthroughs not only in the management of people with VHL, but in the management of kidney cancer in general, and has increased our number of treatments. I'm not talking today about medical treatments, but for metastatic kidney cancer, we now have viable options, both immunotherapy as well as targeted therapy, that can extend people's survival. Early and often screening, predominantly with ultrasound, which is extremely safe, and occasionally with MRI. And we do virtually nothing other than intensify surveillance for people with tumors less than 3 centimeters. And when we intervene, nephron-sparing surgery is the most effective surgery to help this situation, and ablation can be done selectively, but it's not quite as effective. But at all costs, we try to avoid total kidney removal unless it's absolutely necessary. Thanks for your attention.
So maybe we've got time for just one burning question, and then we'll do everything else on the panel, if that's okay.
Thank you. I was wondering if you could comment on the use of gadolinium or other contrast dyes in people with compromised kidney function?
Yeah, sure. It's a great question. So MRI scans in general are done with a dye that's called gadolinium, which is actually a liquid metal. And if a patient has relatively low kidney function, which we define as having a GFR, glomerular filtration rate, of less than 30, and this is not uncommon if someone's had a kidney removed or has some compromised function, there's a toxicity with this dye that can cause a pretty severe and terrible total body systemic fibrotic reaction. So in general, the rate of that is virtually zero in people who have normal kidney function. But as your kidney function goes down, and if you measure that by what we call your creatinine, which is a blood test, that would go up. Different institutions have different cutoffs, but somewhere around a creatinine of 2.0 or higher, most radiology departments will not be comfortable exposing people to gadolinium. There's a couple things about that field that have changed. The gadolinium that causes that reaction is almost never used anymore. There's a newer version of gadolinium, and the vast majority of people who had the reaction were actually on dialysis. Not necessarily from VHL, but they were dialysis patients who had no kidney function. So there's a little bit of an overreaction to the risk. So when someone's creatinine is 1.6 and they're nervous about gadolinium because they don't want to get this syndrome, it's actually never occurred in people like that anywhere.